recording. I'd like to welcome everybody. Hi, this is Mercedes Byrne-Klug with the University of Iowa. I'd like to welcome you to our webinar today on end-of-life issues. It's part of the National Nursing Home Social Work Network webinar series. We also have handouts that accompany today's webinar, and those handouts you can find on the network's website, and the URL is listed in front of you and also in the chat box. To acknowledge the generosity of the Retirement Research Foundation for making these webinars possible. And I'd like to talk a little bit about the webinar series in general. We're providing these webinars in an effort to build knowledge and skills among nursing home social service departments in particular, but really for anybody who's more interested in psychosocial issues affecting America's nursing home residents. Our speakers are generally social workers, but we also have speakers from other disciplines, and we're always looking for practicing BS level nursing home social workers who might be willing to collaborate with us and present a case. So if you're interested in that, please contact me. The certificates of attendance, those who have signed up and registered for today, we have your email and we have your name, and we're also the system take track of how many minutes you've been on. So we'll be sending out by email a certificate of attendance that you, depending on what state you live in, you may be able to use that for CEUs. Please chat box if you have some kind of a logistical challenge, and then I'll try to help you individually while our speakers are presenting. And if you have a question for the presenters, go ahead and put it in the Q&A box. Both of those boxes are to the bottom right of your screen. If you prefer to put the question in the chat box, you can do that too. I'll be watching both boxes throughout the session. This session's being recorded, and the recording will be posted on our website within about 24 hours. We're in the welcome session of the webinar, and then I'm going to hand the mic over to my colleague, Bob Conley, in a minute or so, and he will introduce our topic and then our speakers. And then the game plan is for the speakers to present for about 55 minutes, and then we'll save the last 15 minutes for questions and comments from you. So feel free to type in your questions or comments at any time, and we'll take those at the end. I'd like to introduce Robert Conley, social worker with 20 years experience at the Center for Medicare and Medicaid Services. And in fact, it was Bob who served as a project officer for the MDS 3.0. He's a member of the planning committee and has been from the very beginning, and he's the co-leader of this webinar project. So Bob, take it away.
Thanks, Merce. Topic for today is assisting with end-of-life planning, and I'm very excited about this because this will be followed by a end-of-life and ethics. February, we'll be dealing with something that social work and other disciplines have important roles for. We have two eminently qualified speakers. The first is Coral Munn, who from College of Social Work at Florida State University. And Jean is an associate professor and is directing their multidisciplinary certificate in gerontology program. She has her PhD and master's in social work from Union, North Carolina at Chapel Hill, and her bachelor's in psychology from Duke University. Her work, she was awarded a John Hartford doctoral fellowship and completed her dissertation that really helps our topic today. It was entitled Define a Good Death, Residence in Long-Term Care. She received additional dissertation support from the Duke Institute on Care of End of Life, and in 2007 became a John Hartford Geriatric Social Work Faculty Scholar and Palliative Care Scholar. Our speaker is Jeannine Wilson from Greenwood Center in Sanford, Maine. Jeannine is earned a bachelor's in social work degree from University of Southern Maine and is one of our BSW speakers, and we're delighted to have her. She's the Director of Social Services of an 86-bed nursing and rehabilitation facility in southern Maine. She's been an active member of the Maine POLST Coalition, and she'll be talking about that today. So I'll hand it over to Jean.
And welcome. I'm really happy that you are willing to take time from your busy day to talk about this particular topic. We're hoping that we will help you interpret the role of social workers in long-term care, especially at the end of life, because I know some of you may be new social workers and looking for sort of a guidebook on what you are expect, but also we're going to talk about some specific advanced directives, and we're going to focus on one called the POLST. Also going to talk about the kinds of documentation that are needed when you're working with residents at the end of life. So we're going to do this by beginning with defining the social work role, and then we're going to talk about how you initiate conversations. Specific advanced directives are typically used in long-term care. In detail, we're going to go over the post. That's what my colleague Jeannine Wilson is going to be really focused on. She has great expertise there. And we're also going to talk about how you document in the medical record so that you have both the legal, ethical, and clinical issues documented properly. I'm going to talk about a case study in which you'll be able to see a real-life situation and how that might play out. And we're also going to have an opportunity for you to ask questions and try to respond to those, some of which we may not have the exact answer to, but we certainly will give them our best shot. This idea of defining the social work role is really important because end of life occurs almost daily in long-term care. We know that our nursing homes and assisted living communities are the site of death for about a quarter of the older adults who die in the United States. Of 1.5 million older adults who live in nursing homes, the mortality rate the first year is about 34%, and after the first year, about 24%. So we know that this is an ongoing situation and that you as social workers are likely to be dealing with this situation. So how do we define the social work role? One of the ways that we as social workers can often see what our role might be is by looking at our NHSW standards. Now, the NHSW standards that apply to our particular discussion today include those related to long-term care. NHSW tells us that we are responsible for assessment, treatment, rehabilitation, supportive care, in preserving and enhancing social functioning, that we're to promote the optimal level of psychological, physical, and social functioning. So this is a pretty wide spectrum of responsibilities. And then if we look at the specific directives related to end-of-life care, the NHSW says that we're to advocate for the needs, decisions, and rights of the clients and specifically ensure that people, that's residents in long-term care at the end of life or any people at the end of life, have equal access to resources to meet their biopsychosocial needs in palliative and end-of-life care. So if we look at the NHSW for guidance on our role, we really have a large role in developing the optimal end-of-life experience for clients that are in our care, specifically clients at the end of life in long-term care. We know that working in a nursing home puts us in one of the most regulated environments in the country. And these regulatory requirements are often depicted in the residents' rights, specifically in the Code of Federal Regulations. And we are required by residents' rights and by the Code of Federal Regulations to be responsible for dignity and self-determination. Again, a very high responsibility. We typically work in interdisciplinary teams, and those teams frequently look to the social worker to be the liaison with a resident and to the social worker to actually bring to the interdisciplinary team some of the needs of the resident, but also oftentimes their end-of-life preferences. We know that currently there are quality assurance performance improvement teams in long-term care, and we are members of those teams. We also are participants in the plan of care team, and we are with completing the psychosocial aspects of the assessments. We look in addition to these, if we don't have enough to do, if we look in addition to these three initial sources of information, we've done some empirical studies on the role. In fact, Mercedes Byrne-Klug, who is one of the co-founders of this series, myself and other social work researchers, have done research on what is important at the end of life and where the social worker fits in. One of the research that I did when I was getting my doctorate was involved conducting focus groups with family members, staff, and residents of long-term care of what would actually constitute a good death for them. And what I found from those particular focus groups was that social work involvement really needed. In fact, the nurses would say, the workers don't come and help us. We have to go and find them. So I finished my doctorate and I started as a faculty member. I went back to those same communities and conducted focus groups with the social workers because I wanted to know what the social workers had to say about this particular role. And these social workers told the same story as the nurses, but the meaning was completely different. The social workers said, we depend on the nurses to tell us when they need us. They know the residents best, so we know they'll come get us if they need us. So we were hearing the same story, but it had very different meaning. And it brought up the aspect of actually the world a long-term care facility may define our role to a certain degree. That the social workers told us that when they had multiple residents, that they did not feel that they could take time away from other residents to tend to the needs of one individual resident. So this social work role is not clear. What we're going to have to do is look at and see where we can fit in and where we can be helpful, and that's one of the things that we're going to be working through today. I mentioned the NHSW Directive for Palliative Care. One of the things that seems to be very difficult for social workers or any person working with people at the end of life is really initiating a conversation about end-of-life discussions. We know that that's required upon admission to a long-term care facility, and we know that from research, sometimes we social workers are almost apologetic about bringing up this particular topic, that we feel like people don't have made a mindset for us to discuss it at that point in time, but we're tasked on doing it. We find that some social workers are more comfortable talking about end-of-life issues. We find that those who are older, who are religious, and especially those who have a lot of experience, feel more comfortable and more competent in bringing up this particular topic. Really surprising because we also know that there's not a lot of information in social work curricula regarding end-of-life care. Sometimes there's a specialized course, but we find that it's not always infused into the courses like human behavior in a social environment. And we also know that everyone who is a social worker in a nursing home did not have a social work education. So this is why we feel like we can bring this to you today and hopefully help overcome those barriers of feeling like you don't have quite the information that you need to broach this important subject. We also know that some residents are very hesitant to talk about end of life, but oftentimes the resident may wish to talk about end of life, and we have to listen for those moments when the residents send us that message. Resident families also have some difficulty talking about end of life. And I find that overall, the resident may feel like if they don't talk about this, they're protecting their family from thinking about it. And sometimes the family feels like if they don't talk about these issues, then they're protecting the resident. But once that conversation begins, we often find that the resident and the family, and maybe even the social worker, are really relieved to have that conversation. So we hope we'll give you a little bit of information and some tools to help you develop those conversations and work through this process. We know that some of your facilities have specific policies regarding end-of-life issues, and there are also legal concerns. You know, what is available when end-of-life is near? One of the things that becomes very important is the Patient Self-Determination Act, which does indicate that a patient, or in our case, a resident in long-term care, can refuse any treatment, and that's their legal right. We also know that the facility has a right to transfer the person if their needs cannot be met, given the facility policies. And we also know that a medical doctor can refuse futile treatment. So we do have some legal issues that are important to be aware of. The Patient Self-Determination Act is probably one of the underlying values that is going to lead us in our discussion today. And that requires that at admission into a facility, that the facility provide written information to individuals about their right to make their own medical decisions. The facility personnel ask patients whether they have completed an advance directive, that they offer currently capable individuals a chance to execute an advance directive, and that they have, as a facility, created a system to assure compliance. And furthermore, and sometimes this is also the role of the social worker, that the facility educate the institutional or organizational staff and community about the patient's rights for medical decision making. So again, the social worker has quite a role, and they have to be aware of the barriers, but also the timing. Admin is a good time to have a discussion because we know that at that point in time, we're typically setting some goals for the stay in the long-term care facility. The discharge goal may be, and this is becoming more frequent, to return home, or it may be that the person chooses to return home, but there need to be services in place to allow that, such as palliative or hospice care available in the home. Or we also know that they may choose to stay in the long-term care facility for end-of-life care, and that usually means incorporating either a palliative care program or a hospice care program, or sometimes the facility person or those that conduct the end-of-life treatment themselves. What do we talk about? Well, we typically talk about advance directives. Advance directives fall into sort of two major categories. One is a surrogate instrument, which means that the individual, while they are competent, cognitively intact, designate a health care power of attorney. So the care power of attorney is a person who acts as their surrogate or in their behalf. They not be able to make decisions for themselves. Now, when an individual does have a health care power of attorney and is no longer able to make decisions for himself or herself, individual states typically have a legal hierarchy of decision makers, and it differs from state to state. But an ordinary progression would be the first in the legal hierarchy would be the spouse. If the spouse is not capable of making decisions or is deceased, then likely it would go to the children. And then it continues on based on the availability of those in the upper echelon of the hierarchy. But again, this is state specific is something that we as social workers in long-term care need to be very aware of, because we know that everybody who comes into the facility does not have advance directives and may not be capable of executing them when they enter the facility. The type of advance directives are instructional advance directives, and these give information on what the individual would like to have done. So if the individual has something like a living will or a do not resuscitate order, it's going to explain the medical procedures that the person has chosen or not chosen, and this will be in place regardless of whether the person becomes incompetent or not. So these are instructions that exist beyond the individual's competency. So this opportunity to have advance directives, and we know that they can be completed, we go about making these advance directives or putting them in place or talking to individuals about what their wishes are at the end of life. Well, sometimes we're going to be talking to a variety of stakeholders. We might, at admissions, be talking about the goals, as we mentioned earlier. We might also be talking about a variety of advance directives with a variety of people. We might be talking to a medical power of attorney rather than the individual himself or herself. Sometimes a guardian or a DHHS guardian, sometimes simply an informal representative, and this is all based on the capacity of the individual with whom we're working. We obviously want to involve the resident in every way that we can and with they're comfortable. But we know that some residents want to share the decision-making process. The residents who, despite the fact that they are perfectly capable of making their own decisions, they really want to involve their children or their family or their spouse in the decision-making process. So we need to be open to a model of shared decision-making as well. So since we have some directives, and since we know that we talk about them, we've worked our values and our hesitancy, why would we not just have the situation well in hand? Well, challenges actually to this aspect of end-of-life care. One is that there may be residents without advance directives for a couple of reasons. One is that they have entered the facility at a time where they simply could not make these decisions for themselves, and they may not have anyone who is able to make a decision for them. Or they may choose not to make these decisions, may choose not to have these conversations, or they have a cultural background that makes it, if not difficult, inappropriate to have these types of discussions. Also know that there are some difficulties in interpreting and applying advance directives. It's very hard for healthcare providers and surrogates to know exactly when living will applies. They're really uncomfortable about deciding when a patient is on a dying trajectory, and they honestly may simply not know, regardless of their profession, when a patient is on the dying trajectory. We know from research that the expectation of death is really not a very easy thing to predict. We know that the documents, no matter how well they're crafted and no matter how much they represent the individual's point of view, if they're not with the individual at a given point in time, then they're not available to the healthcare providers. For example, if someone is discharged to the hospital, then if the documents do not go with them, if there's no electronic copy or written copy available to the hospital personnel, then they will not be able to interpret or implement the advance directives. And finally, there are some difficulties actually enforcing advance directives regardless of how well they are written, because a healthcare provider can decide for reasons of personal conscience to carry out an explicitly stated treatment preference, as long as the healthcare provider doesn't impede the efforts of the patient to be transferred in order to get a provider who will carry out those. And so it's just that a healthcare provider is not liable for failure to follow a patient surrogate's instructions to withdraw or withhold particular forms of treatment. We also find that families may have been involved in the decision-making process from the beginning, but at the time that the person is facing death, they may change their decisions. So we know that there's not a perfect enforcement record of advance directives in any settings, and certainly not in long-term care or hospitals. So, have these problems, then what's an alternative? I think that my colleague, Jeannine Wilson, is going to talk to you about an alternative called the POLST, which has been found to overcome some of the disadvantages of other types of advance directives. So I'm going to turn the conversation over to Jeannine Wilson.
Hello, I'm Jeannine. I'm going to talk about the POLST paradigm a little bit, and what a POLST is. It was developed in Oregon in the 1990s, and it is evidence-based for a history of effectiveness. In other words, they said that the survey of the American Geriatric Society did the survey, and it effectively honors the wishes of those with advanced illness and frailty. A colored medical form for seriously ill patients. Ill means, would you be surprised if that person passed away in the next year? If we yes to that question, if you would be surprised, it might not be appropriate for that person. But if that would be surprised and that may happen, then POLST would probably be appropriate for that person. It's by a physician or a nurse practitioner or a physician assistant that requires is a state requirement. Turn patient treatment preferences and the advance directives into medical orders. So back up your advance directive with a doctor's order. And the goal is to ensure that is for treatment are honored. Quality indicator by the National Quality Forum. It's all done in concurrence with the resident or the resident surrogate's wishes. So make sure that those conversations happen. And healthcare providers of the resident's wishes under factual conditions. It delineates specific circumstances. For instance, due necessity or import to the hospital. And it was in conjunction with all the other advance directives. And it's rather than mandated. And we offer it to residents on admission, some not to complete one, but most of them, they're pretty happy to complete one. That's probably a pretty good idea. We're going to go over the POLST a little bit, the sample POST from my state, but in every state they're a little bit differently. Obviously, part is the demographic part, and you want to make sure that you fill out all the demographic information, their date of birth, and gender. The first in Section A on our POLST, CPR, or do not attempt CPR. Obviously, a POLST can be used not to restrict interventions, but to promote interventions that you prefer. So on the first line, you can pick that you do CPR or that you do not allow natural death. The second part E, sections, comfort measures only, and basically that means nursing home or at home. If you're using the DNR, if you're using it at home, you can use that way too. Comfort mission only, you're not going to be transferred to the hospital unless your comfort needs cannot be met in the current setting. I've worked in nursing homes for 7 years now, and I have not encountered a situation where therapy needs could not be met in the current setting. Limited additional interventions include all the care described above and medical treatment and monitoring as indicated. In other words, you can go to the hospital. They're going to avoid intubation. They're going to avoid mechanical ventilation. They can use CPAP or BiPAP if indicated. They're going to do intensive care if possible too. Obviously, the full treatment and includes everything we just talked about above, and intubation and advanced airway interventions, mechanical ventilation, and cardioconversion as indicated, and referring to the hospital. And the little additional orders at the bottom of section E and D. And you can add anything particular that patient wants to say. If you know someone and they say, well, I can have full treatment here if I'm intubated, but I want to be intubated for a short-term goal. And I that for a lot when I make out these short-term goals. Or they time limited. I only want to be on a airway for 2 weeks. Section antibiotics, you can, one of the three, number one is no antibiotics. Number two, determine the use or limitations of antibiotics when the infection occurs. And three is use antibiotics if medically indicated. The difference between the last two was explained to me this way. If you have a pneumonia, you're very sick and you can no longer cough, you can have a lot of antibiotics, but it's not going to help you if you can't cough. In line, they were giving you antibiotics because they were not going to be effective. If you pick the third line, they would try to give you antibiotics even though they felt that they might not be effective. Orders, you can time limit those orders. Section artificially administered nutrition and hydration. Has no nutrition by tube, either through their mouth or their stomach or side. Trial period of nutrition, and the goal, I can put short-term goals if somebody chooses that, if that's their choice, that makes sense to them. And nutrition by tube. No artificially administered fluids. We're talking about IVs here. Try artificial hydration. Again, we often use short-term goals and treatment with artificial administered fluids. If you go down, you'll see that the next is your basis for these orders. It's very important to fill this out. Who did you talk to regarding these orders? So they had an advance directive on file. You want to click the box. Both you, the nurse practitioner, or the physician, we can add a worker to that line in our state. We can check that box. Maybe made a statement to the authorized representative, or the authorized representative, when the advance directive is talking in behalf of the patient. Check off who you discussed this with on the side box. You can our people if there's not enough room with other. I can add, we talked to them. I can add them all in there. The last here is the name of their primary care doctor, even not under the care of their primary care doctor. We put that in there. And the doctor who's signing, or nurse practitioner or whatever, who's signing the form, and their signature line. On the page, the signature line for the person form being made out for, or their representative. So if they signed it with taking this out for Mary Smith. Mary Smith would sign it right here. We'd print her Mary Smith and would write self over here. If Mary Smith's daughter Jane was signing it, we'd put a sign here under her name of authorized representative, because she's medical power of attorney. We'd put Smith, relationship daughter, and medical power of attorney, her and phone number. The address number is very important in case I need to contact them to clarify something on the form. I'll bring this form to you, your title, your phone number at work, and that it was signed. Slideshow. Here we go. Next slide. Well, the POLST is that it is a legal document. It's a signed doctor's orders. It gives more precise information regarding specific treatment options in unique medical circumstances. It is a prescription that a doctor would fill out for you. It's good a year, so they do need to be reviewed. Clinical improvements. Residents' POLST are more likely to have more care consistent with their desires and values. Across the settings of care and remain in the nursing home. It reduces stress on caregivers and provides family with some relief as well. It eliminates those 2 a.m. phone calls. Family wants to get a phone call in the middle of the night saying, "Hey, Grandma's had a heart attack. What do you want us to do?" Had that conversation and fill out a post, and caregivers are informed of your vision and really help eliminate some of those. Less hospital visits. When the conversation with the family, you want to review the advance directives first, because there may be some specific instructions in the advance directives that would help in deciding on the POLST. I also explain to the family members or the residents the terms, and I explain CPR in very specific terms, and it's not an easy thing to explain. I texted them that 87% of people who have CPR in their age group above 80 do positive outcome. I explained to them that it breaks ribs, it could cause pain, and you do usually end up on a ventilator. I claim also that I'm telling them these things not to change their mind or discourage them from choosing full code, just so that they're well informed when they're making their decision. Oftentimes people think that CPR works like it's shown on TV. You know, "Oh, here I come in to save the day, and I'll push on your chest a few times and you'll be just fine." So you want accurate information. And we also have a brochure that the POLST Coalition came up with that does explain some of the terms. Sometimes we're willing to sit down with you and compare POLST, and some people want to take that POLST and the POLST brochure home and discuss it with family members, or just think about it for a while, and whatever you decide is fine. We all explain a little bit, especially if we're talking about artificial nutrition by a tube, about the process. A lot of families are worried about hunger, thirst, and pain. And when the dying process, that being hungry is part of the dying process, and at that time putting food in the stomach is detrimental to their progress, and can sometimes cause other, and explain they will, that they're free from pain, and that there's a way that they can help them with any issues such as swabs and liquids. It helps a lot when you talk to them about this POLST, a lot of mistakes. And we learned from our mistakes. One of our mistakes was do not mail a POLST to family and say, fill this out and send it back. So originally we mailed the POLST to the DHS Guardian and said, fill it out and send it back. And they just sent it back and said, no, thank you, we're not going to do this. So we thought about it and we worked on it, and we're going to have a conversation with the Department of Human Services representative. They had an advance directive. We're going to consider that or their prior code status. And I talked to everybody and considered everything. The doctor and find out what the doctor feels that would be appropriate for this resident. We then write a letter from the doctor. I write the letter as he dictated it, and he sign it. We then complete the POLST and sign it by the doctor and send it to DHH as guardian with self-addressed stamped envelope. It helps to get it. And we have no problem with procedure getting Department of Human Services to understand what we were trying to do. We have a letter from the doctor explaining the reasoning behind the decisions for the code status, and we've talked to the representatives and looked for advance directives of prior code status. I know. We include advance directives in our reviews. At the annual assessment, we also review the POLST with person that is available to review. Either it's the resident or their representative or their medical power of attorney, and any change, if there's any recent change. You don't have to completely do the POLST over if there's no changes, and whatever works best for your system. Doctor just needs to re-sign it and redate it annually if there are no changes. We also, a significant change from our MDS coordinator, we review it at that time to see if there's a need to change a POLST. For instance, if someone had taken a turn for the worst and their family might be thinking that it's time to have hospice on board, would have that conversation, as well as to do not hospitalize and not and things like that. And mission, we review the POLST. We also send a POLST home to our resident and send them home with a green envelope, because our POLST are lime green paper. And the lime paper is recognized by our riskier. And we send one home with them in an envelope that says attention EMS, and this is the same, and the POLST orders are included. This order for life-sustaining treatment, please take to the hospital. So we send home with that. Documentation.
Watch again here for a second and talk a little bit about documentation. We know that it's really important to include documentation anytime that there's a change in the resident's care, and particularly the social worker is likely to be an individual who documents a change in advance directive or end-of-life directive. And this is the purpose of this is to provide the team with the information to care for the resident, but it's also very important to utilize sensitive information only when it's necessary for the resident's care. End of life may put you in a position where you hear a lot of personal information, and this information need not be in the medical record unless it's there to assure that the resident receives the care that he or she wants. Documentation is taking place in the medical chart, and you typically have in the medical chart legal documents related to the end of life. That might include an admissions agreement if in your facility the document goes into the medical chart. Definitely if there's a living will, a healthcare proxy, a durable power of attorney, or any type of guardianship award, these should be in the medical chart. I'm going to take just 1 second to talk about what a durable power of attorney is. It's a little bit different from a medical power of attorney in that this term durable means that this document will be in effect even if the resident becomes incapacitated. So the resident signs durable power of attorney while they are capable of making their own decisions, but once they become incapacitated, this document is still in effect, or actually in full effect. So you want to take care that when you're looking at the types of advance directives, that a power of attorney may or may not be effect when the person becomes incapacitated, but a durable power of attorney will definitely be in effect. So what does the social worker do? Well, it's important that we review, and Jeannine talked to us about a sort of clock that's tied to the assessment process, but also on a regular basis just to look at the medical chart and see, okay, are the advance directives still appropriate? Have expired, because there are expirations on these documents. And also, it is important to continue this conversation. I mentioned earlier that we did focus groups with social workers who worked in long-term care about what their role was in the end-of-life process. And we came up with a theme, which unfortunately we called before and after. When social workers we were talking to were asked what was their role, they would say frequently, we always talk about advance directives at admission, and we help the family clean out the room upon death. And there weren't really any conversations about what was going on between admission and death. So I think it's really important to remember that this is a process and that the condition of chronically ill people changes over time. And wishes may change over time, and their circumstances may change over time. So we don't want to just get everybody's signature and then say, all right, on to the next room. So good documentation is going to be consistently focused on service delivery. It should be objective, non-judgmental. I think if you look at this as if it's written as if the client could read it, the family could read it, then it's going to pass muster. As long as it's organized, it needs to be current, and it needs to be well written. I teach in a college of social work, and we spend quite a bit of time talking about writing because we find that it's one of the things that the people who employ our graduates tell us is really important, and it's something that we see in students as something that generally needs a little bit of work. So organized, current, and well-written are important aspects of documentation. When documenting in specifically to the end of life, you want to be certain that the wishes of the resident are heard throughout all of these conversations. I think sometimes it's a tendency for us to respond to families or other official care providers because they can easily talk to us and they often can complain about us if we don't do what they want them to, but we need to be certain because embedded in this social work role is the role of advocacy. And we need to advocate, even when we're doing documentation, that we make certain that the resident's voice is heard. We do have to acknowledge any clinical decisions or changes, and also need to document any changes to advance directives. And consistently provide this type of information to all members of the team. So when we are talking about a POLST, Jeannine is going to talk about the types of documentation and the system that she has in place at her facility to make sure that the POLST is to everybody's understanding.
Continuity This is how we use the POLST in our facility. Just one of many, and every facility has, different example of this, but it seems to work very well for us. We have a POLST policy in place for our facility. That's very important. And you should also work with your local POLST coalition if you're going to get a policy in place, so that you're going to start needing a POLST in your facility. Talk to them. We have 5 copies in the front of the chart on our lime green number 24 paper. One of the lime green paper is that it does fax and copy without graying out the paper. Put the original POLST in the doctor's order section of our chart, and we keep that to make more copies from. We do mark our copies with a rubber stamp that says copy. And we have orange stickers inside of our charts that say do not resuscitate or do not hospitalize. We also, as a POLST, have standard doctor's orders for the medication administration record, or MAR. If you have a do not resuscitate order in the MAR, it also says see the POLST for further instructions. Because we spoke about earlier, there may be further instructions besides do not resuscitate, such short-term goals. And that your demographic sheet is updated with the current information. For instance, we use the high-tech system, and in our demographic sheet, it has a place where you can check the box to say do not resuscitate or do not hospitalize or do not intubate. We make sure, because that demographic sheet accompanies our residents to emergency rooms and doctors, that it matches the POLST, and so they have good information on both areas. Care, discharge, or transfer. The other is a POLST. It accompanies a resident on discharge to the hospital, and it also accompanies a resident when making a visit to a specialist. It accompanies the residents anytime they're being transferred by ambulance. And the POLST to accompany the resident when they go home. I spoke about a little earlier that we give them a green envelope to put it in. Also, mail a green copy to their primary care physician on discharge, because they may not be aware that a POLST has been initiated. And one of that our POLST coalition is about continuity. When you talk about continuity of care, there was a conversation between the doctors. With the doctor signing the POLST, not on staff at the hospital where the patient is being admitted. And we discussed that, and the doctors discussed that, and one of the things they came up with, well, they had a prescription for Lipitor, you would not consider as a valid prescription, and so they that way that the POLST is valid because that is the wishes of the patient, and whether or not you wanted that particular form in the hospital that the patient is being admitted to, especially if they're, maybe traveling and they're out of state or something, and birds that have gone to Florida, with Jeannine, that they not have that same form. But the resident's wishes, and they're dated and they're signed by a doctor. So we transfer those wishes to their form, or they honor them some other way. They should be honored.
Jeannine, could you speak up just a little bit? I'm getting some messages that people are having a hard time hearing you.
Certainly can. The question continues. Sometimes we have conflicting opinions. One instance where I was completing a POLST with a family member, wife, and the husband said that he would like her to complete the admission paperwork for him. And as we sat down to do this, she said that she wanted a full code for her husband, and I said, okay, and asked her, what she based that on, and she said, that's what I want for him. And so I asked her, what do you think he'd want for himself? And she said, oh, he doesn't want any of this. He doesn't want to have CPR at all. And I said, well, this is about what he wants. So let's take this paper down to the room and we'll talk to him about it. And we'll continue the conversation between the husband and wife. She began to understand that it needed to be what he wanted and not what she wanted on that form. We've an instance where the family felt that it was their job to decide for a capacitated person, and I had to say to the family that you certainly can talk to her about your thoughts on the POLST form, but it's really up to the capacitated person to her own mind up and complete her form. We're going to not match advanced directives because we're going to do that a little bit more. And I think we've already kind of talked about the guardianship situation and how to work with the Department of Human Services to promote the POLST form. Study, and I'm going to this case study. Ms. Hurst, age 80, was admitted to a dementia care center by her son. She is now in the middle stages of dementia and not able to make decisions for herself. Her Michael is her medical power of attorney. He's by the social worker to meet with her about completing a POLST. Mrs. Parkhurst's advanced directive to the social worker that he had completed when she was 67, indicating full code. He also spoke to the social worker in detail about a dinner he had with his mother about 2 years earlier. It was a birthday dinner. And said to him at the time, if she ever had dementia and wasn't able to make decisions for herself, she did not want to have any extraordinary means taken to extend her life. He remembered the date of the dinner and the name of the restaurant where they had this conversation. So put these questions out for you to think about and perhaps comment on. What should be included in this decision? How Mrs. Parkhurst's son complete her POLST and documented in the social worker notes. So we're going to give a few minutes to think about that and type your answers in the question and answer section.
Folks want to type in who should be included, who included in the conversation. Well, while we're waiting, there were some questions that came in earlier. So, Jean and Jeannine, is it okay if I go ahead and ask?
Certainly.
Okay. Let's see. The general question, has anyone been told that the Catholic Church does not approve of the POLST?
That one. We have worked very carefully with the Catholic Church. I know
this is Jeannine speaking?
Yes, I'm sorry.
Jeannine in Maine. Okay, thank you.
Yeah.
Go ahead.
We very carefully with the Catholic Diocese in the state of Maine. It approved in the state of Maine through Catholic Diocese. They do not have an issue with it. There was a fortunate article that came out about 2 years ago on a Catholic Digest that talked about POLST, but to be honest, they don't understand what a POLST was and what the actions of the POLST were for the resident or the person filling it out. And that's really unfortunate because I know that was circulated and we talked out with the Catholic Church here. We talked to the priests representing the bishops here, and once clear information and real information was presented, there was not an issue.
All right, thank you. And let's remember, the POLST is a tool for people to indicate the kind of care they'd like. So if somebody wanted fair, then they would use the POLST to communicate that. So the POLST doesn't say what kind of care to get. It's the tool that communicates what kind of care the person would like. Thanks for that. Let's see. Another question: Can you think of some examples of what might not be appropriate to include in documentation? So when you have the documentation related to advanced directives or related to having the POLST, are there things that you want to avoid putting in your social work documentation?
Start the answer to that. This is Jean, and then I also would like to hear Jeannine's comments. I would say, first and foremost, no gentle or punitive language. I would never say something like, this family has finally come together after weeks of acrimony, decided on this type of treatment. So those are the types of things I would say definitely leave out. I think it's always best to be factual, to report observable information. If I were even talking about, say, that a resident was anxious about something, I would report the behavior that made me think that the resident was anxious. Like the resident was if the resident is very anxious about discussing end of life, I would say as evidenced by a face expression or a verbal discussion or something like that. So I think it's the editorializing that I would say is very important not to include.
Jeannine, do you have anything to add to that?
Well, that was perfect. I guess I want to be cool about sometimes you get that shared with the whole medical team, the issues that might be private, or something like that didn't have bearing on or the decision that was made. Sometimes people see social worker badge and open up about things that we don't want to share. So that's all I can think of.
I have had a few responses to the case study question in terms of who should be included to this decision, and one person said every that was discussed prior to this day, the power of attorney, the POLST, the discussion with the doctor and the social worker, and all and other parties present, if any. And we had a response from Robin saying, Mrs. Hurst, the doctor, other family members, who should be included in the discussion. And then number 2, in terms of how should Mrs. Parkhurst's son complete the POLST, Ron suggesting consider what he knew about her most recent wishes and look at what the doctor says. And number 3, what should be documented in the social worker notes. Robin suggesting that Mrs. Parkhurst has limited ability and does not completely understand, but has indicated certain feelings and has agreed upon what she has expressed as her wishes most recently. Others have chimed in and said we just need to make sure that the resident's wishes are being honored. That's the main point there.
No good answers. I want to point out that she has a medical power of attorney and advanced directive that indicated full code. So this is a controversy between it said full code and she says she doesn't want her life extended. So in this particular case, did on her wishes that she realized to her son at that dinner, and felt with good notation that they had enough information to indicate do not resuscitate.
Probably taking into account that completed those early wishes at age 67, and now it's 13 years later, and she's in the middle stages of dementia. But I think you bring up a really good point, Jeannine, that advanced care planning is a process. just an event. So had we continued to revisit these decisions, every couple of years, there wouldn't have been that 13-year gap. And so especially going forward, we need to work as consistently as we can with residents who are not necessarily used to updating their advanced directives on a regular basis. Hopefully in the future that'll be more automatic for people, but it's still kind of a new idea to a lot of folks. There was a question that came in also about something that just Jeannine had mentioned earlier. Could you briefly explain the statement that doctors are not liable to follow patients' explicit requests?
That was, go ahead.
Jeannine, was that me?
Well, I'm not sure who said it. I'm sorry. Go ahead.
That's okay.
Okay, it actually comes from, and Merce, I can move this forward, move slides forward. I'd like to get to the resources page.
Okay, hang on a second.
The key resources page.
Jean, you now have there you go.
Okay. All right, and I think it's good to point these out. But look at the second resource. There is a gentleman named Marshall Kapp who is actually at Florida State University. We have here a very unique center for the intersection of medicine and law. And he writes often on, in fact, he and an MD at the College of Medicine actually head up the POLST coalition in Florida. And he writes legally, both a doctor and an attorney. He writes legally about these aspects. And this is directly from one of his patients. And it say that court declined to hold healthcare providers liable for failure to follow a patient or surrogate's instructions to withdraw or withhold particular forms of treatment. And it also says, and I'm reading directly from one of his documents, physician noncompliance with patient wishes to limit medical interventions that have been expressed in ADs is not an uncommon occurrence. So if the physician says, I'm not going to agree with this, he's not being held legally liable for that.
One of the difficulties with advanced directives, Jean, and everybody out there that's listening, is they're like 15 pages long, and in an emergency situation, they are certainly not going to look at them. They're vague. They say, if this happens, then maybe I want this. So they're vague. That's the reason why we developed the POLST, because the POLST is specific, it's a signed doctor's order. So there's strong suggestion to your doctor for your needs, but if your doctor hasn't seen you in 3 years, he doesn't remember what your advanced directive says. And in a situation, you might not have your own doctor anyway.
Thank you. Also, one clarification or one distinction, the POLST is a medical order effective now. The advanced directive is what a person might want in the future. Somebody is enacting that advanced directive while they still have the ability to think and weigh consequences and communicate what they think they might want in the future. So that's another way that those two instruments are a little bit different. We have another question here. In instances where patients don't have an advanced directive, so there's no advanced directive and there's no spouse, who as it relates to a legal hierarchy, if a patient has more than one child, listen to.
Every state, my state says the firstborn child.
It would be important to look to see what that list is in each state.
I think that's the important issue. This is Jean. I think it's important that we recognize that as social workers, we need to make ourselves aware of our individual states' hierarchy of decision making.
I know there's the issue of legally who has the final say, but as a process professional, as social workers are, you like to be able to get the family on the same page, right? You'd like to have agreement and consensus, if at all possible, going forward. So you're going to want to talk with people. If there is disagreement, maybe call a family meeting, find out what the disagreement is related to if you can. There may be different understandings of what the prognosis is or even what the diagnosis is. And there might be differences in opinion of what the resident wanted. So once you have a better idea of is this a family that may need more information, or is this a family that may need some support? The question that came in earlier about the Catholic Church, there may be one of the children who believes that what they're about to decide is not in keeping with their religious beliefs. You know, until we know what the situation is that's causing a wedge within this family, it's harder to be of help to them. So ideally, people would be on the same page, and the same page would be respecting what the nursing home resident had somehow communicated. But in the real world, there's all sorts of issues that you work with every day, family members who don't talk to each other, or just lots of ways in which things can get complicated. That's when you also can be pulling in your director of nursing, pulling in the medical director, pulling in the ombudsman area, getting the resources that this family may need to make the decisions that the resident would make if the resident could. That's our standard. What would this decide if he or she were able to communicate their decision? That's what the family is supposed to be doing.
And sometimes that's very important. What do you think that they would want? And some family members don't get that. You have to remind them several times that this is what you think they would want, not what you for them.
And there was a little bit of a misinterpretation. We had something in the chat box that said, well, then why bother to go through the process of doing a POLST or of a power of attorney? This defeats the purpose if the physicians don't have to pay attention. I don't think that's what we were seeing. A POLST is a medical order. A POLST is to be followed. It's a medical order that communicates that the physician has with the resident, him or herself, or the resident's guardian, to say this is how this person should be treated. I think what our speakers might have been implying was that just as I, Mercedes Byrne-Klug, want my physician to do something and I put it in writing, it doesn't obligate my physician to do something. The physician is still responsible for making decisions, and if there's a disagreement, then I have the right to switch physicians, but I can't force my physician to do something that I said I might want at some point. Is that correct, Jean and Jeannine? Respond to that, the whole sense of it defeats the purpose of the conversation about the physician.
The directive is a strong suggestion to your doctor, and in the best case scenario, your doctor is going to talk about that advance directive, put his file, and hope that that's available on his wishes. With POLST, you have a doctor's order to back up your advance directive. A doctor is much stronger than the advance directive.
That particular comment came as a challenge to advance directives, which is sort of the segue into why there is an alternative called a POLST.
Directives tell other things beside what's on the POLST. Talk about end of life care, full homes, funerals, and also indicate a medical power of attorney. Ours does here in the state of Maine. They have a lot of different wishes about how you want your life to the end of life that are great And well, especially if you're a resident of a nursing home and you have a hospice team, they're going to look over that advance directive very carefully and try to honor all your wishes. But in an emergency situation, the advance directive has less weight than a POLST. Does that make sense?
Yes. Also, remember that in most cases, most health professionals want to do what the resident would want as well. Cases, but in most cases. And either way, the health provider needs to know what the preferences of the patient or the resident, what those preferences are, and then it's a process of trying to direct those to the extent possible, but a health professional also has a part of this decision, saying this, then in her opinion or his opinion, what the person wants may or may not be appropriate. I mean, if I go to the physician today and say I want my arm in a cast, but they don't find that it's broken, they don't have to put my arm in a cast. So what we're doing is trying to make sure that the health professionals have the information, that the resident has the information, that the family has the information, and then that people's values are able to come through in terms of whether or not they want additional medical care and what kind of care they want. And that's what the POLST does. The POLST takes that conversation and turns it into a medical order, a doctor's order, so that in the event that this person is taken by ambulance or goes to another healthcare setting, the doctor's order is much more clear and much more concrete about what kind of care should be given to this person than advance directive.
And that's back to that study that I talked about from the American Geriatric Society that says POLST is very effective at honoring the wishes of those with advanced illness and frailty. So it has been proven to show that they get wishes honored a lot more often than they would have.
It's more likely that somebody's wishes would be honored. Very good. Thank you. I don't see any more questions or comments in our chat box. I'd like to thank the audience for contributing your questions and your comments. And I really want to thank Jean Munn and Jeannine Wilson for sharing your expertise with us. We will be posting the recording of this in about 24 hours. And for now, we're finished. So thank you very much. Bye-bye.
Thank you, Mercedes.
Jean and Mercedes. Thank
Bye.
you, Bob.